Dr. Murthy. I thought that was a really nice presentation. And clearly, I'm sure that all of you would have seen there's a lot of commonality between each of the different presentations. And it raises the question about building better alignment between each of the research groups that are interested in microsampling and trying not to have unnecessarily duplication of effort. And so I wonder whether or not any of either Dr. Murthy, firstly, or then any of the other presenters would like to comment about any opportunities for collaboration, so using the progress which another group has been able to make for their own benefit to then enable some larger, more meaningful studies to be undertaken so that we can get this more rapid translation of microsampling into clinical practice.
I mean, that's a great point. I think we have been we are in the process of establishing collaboration with Dr. Susie Parker's team. So that's, I think we want to expand that beyond, like, I do see from the presentations, I think Dr. Susie Parker is collaborating with many of the clinical teams in Australia and outside, but I think that's a very good point. I think we have an opportunity to further expand this collaboration.
I think certainly, Jason, the guys from the UK looking at potentially a point of care type of measurement would be very interesting for us in the ICU. I mean, that would be an amazing leap in technology and our ability to inform dosing decisions.
Wonder if, Jan Willem, you have quite a big network of collaborators, particularly in Europe, but also more broadly than that. What are your thoughts on sort of trying to find a more structured approach to bring everyone together such that the people aren't duplicating the work that others are doing?
Yeah, I fully support that, Jason. Thank you for your question. Because we see when we review the different studies, approaches are slightly different in how we approach our validation strategies. And I think that mostly affects our clinical validation and not our validation in the laboratories. And also the application in clinical settings. So what do we consider acceptable with respect to drying time and variability, etc. Because in some situations you not be able to use routine sampling, and although the dried blood spot may not produce the most accurate result, it will still be making and supporting clinical decisions. So one of our previous papers on TB, where the variability was not within 15%, but within 20%, that is considered not acceptable, but it supported clinical decision making in a situation where otherwise there would nothing be available. So I think we should look a little bit beyond what we normally consider acceptable in our high resource settings, and also look at the clinical implications. Yeah, it would be great to set up a network to support that message.
Thank you. Christoph, someone who's really pioneered this area, done amazing things in the area, particularly of toxicology, but obviously far broader than that. What are your thoughts on this more broadly, and what sort of strategies could be employed to allow that better alignment?
Yeah, like you mentioned, having some kind of network in which you can get more easily access to sufficient number of patients, because sometimes that's the limiting factor, getting access to the patients, and that may be facilitated obviously if you work multicentric, and in a sense working multicentric also allows you to compare practices that may be present in different labs. For instance, just a very stupid thing for the path determination in dried blood microsamples. We know that it's very critical how the sample processing is done. So actually we teamed up with another lab in Brussels, and it took us several months before we actually got the same results for the same samples. So which may seem strange, but if it has to do with and that is more tricky with dried samples, the robustness of the extraction procedure, how long you incubate something with, for instance, certain standard with blood to generate calibration lines and so on. Those are all things that may not be relevant if you look in just liquid blood, but that may become relevant if you work with dried blood. So we've now actually we're very cautious with extractability issues, because you can do a whole validation and your QCs, everything can be entirely right. You can measure a sample in a right way if it has the right age, as to say, but if it's a week older, you may get an issue, not because of stability, but because of extractability. So those are all hard lessons we also learned along the way. But also, if you work multicentric, and so that's getting back to that, that may help to be aware of all those issues, because anyone can deliver results, and the key thing is being sure that that result is correct and that someone else can actually replicate that result. That holds true in our field, in forensics and toxicology, but also obviously holds true if you work on drug dosing. You don't want a sample to give a different result if it's analyzed in Brisbane, or if it's analyzed in Sydney or in Ghent. So those are all things that are important. And like that, yeah, you actually help to improve the field as well.
I think it highlights a limitation of microsampling, where we collect so few samples. Perhaps say with the VAMs, we might just collect a duplicate sample, and that inter-laboratory testing can be very challenging. But I think you're right that proficiency testing could be performed with quality control samples. Rather than
and preferentially, that's also a lesson we learned. Preferentially, the quality control samples are real samples, because we've had procedures that worked perfect with proficiency tests samples, and so you have procedure A, procedure B, both give the correct result for proficiency test samples, but they give a quite different result if you look at real samples. And so again, that had to do with extractability. So yeah, there's so many tricky things that you may come across that we really prefer to work on real samples rather than spiked ones, rather than just we do include proficiency samples as well, but we also routinely run, let's say, real samples for which we have some established charts for which we keep track.
And Christophe, do you prepare those? Is that a pooled clinical sample that, and then you prepare them in the laboratory?
So that's fine. So the advantage is that you don't need a lot. So even with one tube of blood, you can generate samples. So, and if long-term stability at room temperature would not be fine, you can still freeze them at -80 and then thaw them batch-wise again. So depending on stability, it may differ, but that's what we prefer, working with batches of real samples that we run across our analysis.
Yeah. And I mean, that's a similar result to a study we performed where we were collecting plasma samples, and even with the absence of hematocrit, we were still seeing an effect of recovery across time. And so I think it's definitely a side to the microsampling that we need to keep.
No, we've also learned it the hard way. There's several students have redone an entire validation just because something unexpected appeared, and now we try to anticipate on all those things early on.
I wanted to make a comment about in thinking about collaborative opportunities. something which we have done in the past is to combine data sets of the same drug in different patient populations, and then to perform an analysis to understand the effect of the indication, or alternatively the patient type, and how we can describe that in a pharmacometric sense. But I wonder whether or not that's perhaps a little bit more fraught with danger here because of the bioanalytical issues that have been raised so far, and that maybe that approach in the current context of the way that these studies are performed and the lack of uniformity over the results that may come through may mean that we could falsely suggest that there are differences if we're combining microsampling data sets and say that that's related to the patient population, but actually it is just inter-lab variability in data.
Yeah, it depends how you look at it. I'd say you can look at it in different ways. On microsampling may also allow you to easily send a sample from one part of the world to another, so that you only have one analyzing lab. So you can have, for instance, 10, 20, 30 clinical centers that do the sampling, and just send the samples to one site. We have plans to start up a multidisciplinary or a multicentric study where we will receive samples from different places in the US. We are now already analyzing in a routine way samples that we get on a daily basis from the UK. So that makes things easier. Actually, I'd say. Obviously, you want to do the analysis in multiple centers. That requires an additional level of control. But again, there you can easily send over samples between labs without all the hassle of biological samples entering Australia or the US and so on, with all the regulations that are associated with it. So sample exchange becomes quite easy.
Thanks. And a question for Dr. Murthy is that one of our pediatric intensive care unit pharmacists here in Brisbane's asked about furosemide or furosemide TDM. You made a comment about that being one of the analytes that you look at in your microsampling. Do you know much about how that TDM for furosemide is performed?
It's a great question. It's not really like a TDM. It's really understanding the PK/PD to really better define the dose in that population, right? In the NICU setting. So it's not like therapeutic drug monitoring to say like other drugs, but it's rather the data, like understanding a PK/PD in the neonatal population is very limited based on the literature. So one of our young doctors is leading the effort to understand the various, factors that may impact the treatment of the particular population.
Yep, that makes a lot of sense. We've done a similar study in adults, but with macro samples, and I think that that's highly relevant. Okay, well,